I like to remind my patients, I'm on your side. This is a teamwork decision, and it's not me versus you or my decision versus yours. And so that really allows us both to aim towards the common goal, which is for the patient to be happy with their result.
This podcast is brought to you by Mane and Steel, hair for life. Welcome to the Mane and Steel podcast. Discussions on hair loss, men's health, style, confidence, and everything in between. Okay, Dr. Parissis, thank you for joining me today. We've been trying to do this for a while now, and we finally have it together. So thanks again for joining me across the pond. And you're not in surgery today, huh?
No. So we're at 6 p.m. here. Not in surgery today. I took a break over the holidays and New Year period. So with the family over in Belfast. So my clinic's over in London, but my family is based in Belfast. So here for a little while. Yeah, I'm super glad to be joining you today, Chris. Thank you for inviting me. It's a pleasure.
And I don't really have a background. I didn't speak deeply on this with you prior on Instagram and stuff. So for those who don't know, tell us a little bit about your background from medical school standpoint. So where'd you go to medical school? What did you study to get into hair transplantation?
Yeah, that's a great question. I went to medical school in university called University College London in central London. And about halfway through that, started experiencing my own hair loss. Obviously very bothered by it and looked for solutions. Stumbled across Dr. Bloxham over in New York. And at the time, there wasn't many options in terms of hair transplant clinics, at least good ones, in my opinion, at the time in the UK. So I thought I'd fly across the pond, go to New York, where amazing results were being achieved by Dr. Bloxham and Dr. Feller at the time. And I got a hair transplant at the end of medical school with Dr. Bloxham. And funnily enough, before I had left my surgery, me and Dr. Bloxham discussed partnering together and him teaching me the ropes, if you like. So for the rest of medical school, I essentially knew what I wanted to do. I knew that learning about the anatomy of the heart and the kidneys would be relevant, but I also really wanted to just learn about hair. And unfortunately, medical school doesn't really give that much teaching on hair loss and hair transplants. So that was something I kind of outsourced myself, trained with Dr. Bloxham as I was a general medical doctor and A&E, or over in the US, it's called ER doctor. Yeah. So I was an ER doctor for a few years, and I was working with Dr. Bloxham every once in a while to train. And then up until now, I've then established my own hair transplant clinic in London. We've been open for a year now, and things are busier than ever. This field is exploding, thankfully. And the main aim is to bring and deliver the same high quality results that I was looking for back, when I was a hair transplant patient, to try and bring those over to the UK. And I believe so far, luckily I've managed to achieve that. So hopefully I'll continue like that.
So a couple things guys will always ask. Number one, what's your hair loss stack? So medication wise, what are you currently on, and what were you on prior to surgery, and what have you maintained, or what medications have you been on?
Yeah, it's a good question. The current hair loss stack is very different to the first hair loss stack I was on. So the first hair loss stack, it has changed throughout the years. At my peak, I was on the strongest medication, which were dutasteride 0.5 milligrams and oral minoxidil 2.5 milligrams. So I do believe that dutasteride and oral minoxidil are the most powerful agents against male pattern baldness that we have. And so, I kind of threw the kitchen sink at it and decided to hop on those medications. And unfortunately, I experienced side effects myself. Now, I have many patients who are taking those medications with no problems, but I wasn't, in that boat. So had to pull back on the dutasteride. I'm currently taking finasteride 1 milligram per day. So I believe that's a kind of a nice balance for my body of slowing down hair loss, but also preventing side effects. So it's a classic bread and butter medication there. And I haven't actually formally announced this, but I'm taking oral minoxidil again. I had a YouTube series where I talked about the side effects that I got from the higher dose of oral minoxidil that I was taking. Yeah. A few people might be surprised to hear that I've restarted it, but essentially the benefits of it were just too tempting. I felt I had to try again just because of that overall density boost that oral minoxidil brings. And so just 3 months ago, I reintroduced oral minoxidil, but at an extremely low dose. So I'm taking 0.625 milligrams, which is probably the lowest effective dose that is seen in the research. Better than nothing. And I haven't seen much of an improvement so far in the last 3 months, but I also haven't had any side effects either. So gonna make a video on that in probably another 3 to 6 months time. But yeah, so that's the current stack really, on the gentle side, but I think it makes a big difference for me.
Yeah. And you and I spoke about specifically oral minoxidil side effects. I think you and I had the same thing. Get that weird rosacea underneath your skin. And anyone can look this up. The side effects for oral minoxidil are the big three, like some rosacea, water retention, and you get a little bit of orbital water retention here and here throughout the body, and then blood pressure changes because it's essentially a blood pressure medication. And the two that I experienced was getting that weird like rosacea, some acne, and I don't ever get acne. Dutasteride helps mitigate that. Most people don't know that. But I started to get weird rosacea right under here, and I did notice periorbital swelling in here. And the biggest thing, which my girlfriend hated the most, was nocturina, otherwise known as nighttime peeing, because when you retain water, and I was on 5 milligrams, the highest dose we could go, and I had dropped down a couple times to 2.5. But even at lower doses, I just kept experiencing nocturina, just urinating at night, and it just kept me awake. And I was like, oh my gosh. Or we'd go for walks together in the evening, and I would have to go to the bathroom. So I had a lot of water retention, and I could physically see it specifically in my face, my jawline, my periorbital region. And then the second biggest one was just urinating a lot. And it was just too much. It was disrupting my sleep. So right now, my current stack, which shocks a lot of people, I'm titrating up on dutasteride. I guess you could say testing through my own company. I'm at 1.5 milligrams dutasteride. I originally started at like 0.5, and then I went up to 1, and then 1.5. No, so I've never had side effects from 5-alpha reductase inhibitors, even early on when I started Propecia and finasteride back in the early 2000s. When it was getting mainstream. And just going off all the research for dutasteride, I just like the research and I like the effects it's had on me. Specifically, I always mention this, not a lot of shedding on dutasteride. I think a lot of it has to do with half-life, but I've never really had any side effects with 5-alpha reductase inhibitors. I think there are other advantages to some of these medications. It helps with your hair, skin. It can stop or mitigate some, I guess you could say, acne, which is why a lot of guys who are on TRT, I believe, should be on these medications to help mitigate the symptoms of increased sebum production and stuff, which can cause acne on the back, acne on the face, as well as, hair loss because you're increasing DHT. So that's good to hear that you are testing again. And that's kind of what the process is of hair loss, right? You're kind of trying new things out, assessing how you are personally. And I think one of the big things that guys don't realize is there's always a way to titrate up or down, but you have to be very aware of these medications. You should track your progress. You should track the way your hair looks, the way you feel. And I think that gives us a better gauge of how we can assess someone personally on a medication versus just looking at the research and saying, okay, let's just go right into research, but giving people options in these medications so they can go up or go down depending on their symptoms.
For sure. There's no one who knows their body more than, yourself. You know your body the best. And I envy that you haven't had any side effects from dutasteride, especially 1.5 milligrams of it. And I see why you might consider that, because there's one particular paper I can think of that suggests that a higher dose of dutasteride, even above 0.5 milligrams, can actually reduce scalp DHT.
The Olson study.
Yeah. And that rings a bell. It suggests that it can reduce scalp DHT even further than traditional 0.5 milligrams of dutasteride. So that makes perfect sense. And then what you said about oral minoxidil, I do see evidence of fluid retention in some patients. I tend to prescribe much lower than 5 milligrams now. 1.25 milligrams is really well tolerated in my patients. Are you taking oral minoxidil anymore, or you're not anymore?
No, I stopped probably, I think I titrated down, which I say this to guys, oral minoxidil is a little bit different. Be careful just stopping that abruptly because you can have some weird heart effects. So I tell patients, cut it in half and go down slowly throughout the week. So I cut down all the way about 3 or 4 months ago. I would say I noticed after that first month a little bit of shedding in my hair, and now it's because you're losing some of that. I haven't really noticed a change in thickness or anything. A little bit less body hair, I guess you could say, because it does increase body hair, but nothing really differentiating that I could see. The base is blocking DHT, and minoxidil is this adjunct, right? I always tell this to guys, DHT blocking is your number one. That is the compounding effect you're going to have. These medications, specifically 5-alpha reductase inhibitors, have this compounding effect. And Mr. Rolandis and I talked about this just the other day on our podcast about you can see the results, not within 3 to 6 months. A lot of my competitors in this space will tell you, oh, grow all your hair back. That's not true. These medications take years. DHT blockers take years, but give you compounding, lasting results. And I remember this in particular. One patient I was treating, older gentleman, as a physical therapist. I'm not a medical doctor by trade. I'm a doctor of physical therapy, but I was treating this gentleman over the course of months, helping him walk and stuff. Older guy, and he was on 5 milligrams of finasteride, and it was in his chart for benign prostate hyperplasia. But I saw old photos of him, and then I saw his hair now, and It was incredible to see his old photos. He never had a hair transplant. How thick his hair was from the prostate dosage of finasteride. I was like kind of in shock because I could physically in his house see his older photos where his hair was kind of thin in close-up photos. And then looking at him, I was like, what the heck? And this was years of taking this. So these medications, they take years to really see the compounding effects. And you'll come across guys in the medical field or patients who have said, yeah, I've been on it for years. And you can look at photos. Photo evidence shows they do have a long compounding effect versus oral minoxidil, which is that adjunct to help grow the football field, grow the grass, right? I think that's what a lot of people kind of misunderstand there. But yeah, also one other question, as it just popped in my head with Dr. Bloxham, what type of surgery did you have?
Yeah, I had a strip FUT procedure. So for those of you that know, there's two types of hair transplant techniques, FUE and FUT. And FUE takes individual hair follicles from the back and sides of the head and implants them to the bald areas. But strip FUT takes a strip of hair-bearing skin. We give that strip to our team of technicians who dissect that strip into individual hair follicles. And just like FUE, we then implant those follicles into the bald areas. So my first experience with hair transplant surgery was with FUT. And, one of the lucky patients who managed to get a good result, I think. I was happy with it. I'm glad that I chose FUT because the rest of my donor area is completely virgin. It's untouched now. It is ready for more harvesting should I lose more hair in the future, which is highly likely because I still have 30% of my DHT in my system. I'm blocking 70% with finasteride, but I still have 30% left. So I know that 30% is chipping away at my hair follicles. It's just doing it slower than it would have without finasteride. So I know that I'm going to be due for more loss in the future. I've done strip FUT to harvest just 100% of the grafts within that strip area. And the rest of my donor area is ready to go for future procedures. So I don't regret it. I do have a linear scar back there, but I wear my hair beyond a 3 on the haircut scale. And so it's not visible. I have a hard time finding it at times. So I got lucky in many regards. And I really believe in providing both FUT and FUE to my patients because I personally experienced the benefits of FUT. And I know you did too. And I don't want this to necessarily turn into an FUT, pro FUT only. My advocacy is that both are needed and both are helpful. The combination of both is the most powerful approach to hair transplant surgery that we have currently.
Yeah, I agree. I just had a bad experience with my first FUE, so I switched over to FUT. That doesn't mean I'm not going to go back. Dr. Blocks and I have talked about doing a combo on my next one to fill in my crown, FUT, a little bit of FUT. I can probably get one more strip and then add in some FUE to that. So I'm not opposed to either. And there are some surgeons who only do FUE and they continually produce great results. That's just the truth. So I'm not opposed to either one. It's individual, right? I think a lot of guys need to understand that. It's what is the best for your case. I think severe hair loss should always start with FUT just because you want to preserve that donor to maximize coverage. But some surgeons don't do that and they still get great results with FUE only. So case by case, doctor by doctor, I think that's a big thing we need to look at. And we'll touch on more on a lot of this. I have some intricacy of surgical questions that I'll ask you too. I always ask my dad. My dad was a surgeon. He was not a hair transplant surgeon, but it's always funny to talk to him about certain types of surgical techniques, differentiations and stuff, taking out a gallbladder, taking out an appendix. There's a couple ways most people don't know, but it's always fun to talk to him about certain things and how he'll tell me, oh, I could pull an appendix out with 1-inch scar. I'd get in there and get in there. It's really cool to hear the surgical techniques, even though I'm not a surgeon, I've gone through dissection. It's really cool to understand the intricacies. And I think a lot more patients who are going into surgery should learn them because it gives you a better understanding of what will work best for you, what you might be scared of, what you shouldn't be scared of in surgery, because these are minor procedures, but they take a long time to heal. And a lot of guys don't think about that. They just think the end result. And I think we should educate more guys on the intricacies of surgery, how they work, and guys should just go online and read about it. Learn about the surgery. It's very interesting. It's kind of gross looking at the strip and other things, but it's cool. And it gives you a better understanding of what you're going into and what the expectation should be for you as a patient to heal. So that being said, let's jump into some more, I guess we'll say, trending topics here. Something that I always love to bring up is like celebrity hairstyle, why it matters, and how celebrities really do have a precedence on the hairstyles we choose, what we have in expectations, and what we want in the future for our own hair, be it young guys, old guys, new guys. So can you think of like one actor, musician, athlete, could be UK, America, who's had like, not a hair transplant, an incredible hairline or great hairstyles like throughout their career?
For sure. The obvious one that I'm sure comes to everyone's mind is Brad Pitt. The movie star has been around for must be 30 years now. And he is a very lucky individual when it comes to hair because he hasn't lost a single hair on his head. His hairline is completely intact. And if you look at the photos, it's exactly the same as when he was younger. So certainly blessed in that regard. And I think he's an example of someone who has varied his hairstyle so much that it really illustrates the power of hair. There's even this theory that Brad Pitt has matched his partner, whoever he's been dating, he's been matching the hairstyle of his partner. So if you look at the photos of him with Gwyneth Paltrow, he had his hair straight and blonde. If you look at his hair with Angelina Jolie, it was a little darker, I believe. And the same with Jennifer Aniston. He's quite literally changed his appearance, transformed his appearance because of his hair. And he does so in movie roles. And it is a very good example of the power of hair. And that's why, we all want to keep our hair. And that's why we're having this discussion, because it is important. I think he's a perfect example of that.
Quick word from our sponsor, Mane & Steel. I started this company because of my own experience with hair loss. Mane & Steel is the first and only company in the US offering dutasteride-only protocols, the most effective medication we have for stopping hair loss and helping regrowth. Whether you're in your 20s, 30s, or 40s, or you just want to keep your hair, Mane & Steel is built for long-term results. Trust me, it's a lot cheaper than spending thousands on hair transplants. Go to maneandsteel.com and use code HEROSHOT for 10% off your first 3-month subscription. Now, back to the show. Yeah, it shapes you, it guides your style. And I saw Brad Pitt once when I lived in Hollywood. He was on his motorcycle on Ventura Boulevard. Just looked incredible. Had his helmet on, so I didn't see what hairstyle he was sporting at that time. But it is a testament to the power of hair and how a hairstyle can follow you with trends, can follow you with your career. And some guys, just have that same hairstyle throughout most of their career. Kurt Russell, great example, just the flowing mullet that never really left the 80s, but it continues to work well. And a lot of people don't understand the psychological benefits to, I wish I had Brad Pitt great hair and temples, but when you have that, your confidence completely changes. When you have a great head of hair, it alters the way you walk, the way you talk, the way you act in life, the way you feel inside your home and the way you feel outside your home. And that's something that's not talked about a lot. And I think that's why we get into this space for medication, for surgery, is to help guys improve their confidence, improve their look, not vanity. It's not vanity. It's a way to make you feel confident about yourself. And that's probably why Brad Pitt does. I think he's aware that he has great hair. If you look at him walking into places, he's confident just walking into a studio or we'll say on a red carpet. He never looks like he's down and out. He's just floating almost, right? Yeah. And I think that's a testament to having great hair. Is there someone whose hair always works on screen, or like any broadcasters that you know? I can think of some, I guess football, not soccer, but football here in America. Any broadcasters you would say who always kind of pop up on screen and you're like, man, that guy's got a great head of hair?
I can't think of anyone right now.
I think of a lot of guys in like football in America. Like Troy Aikman is older, still has great hair. Aaron Rodgers is still a football player. He will probably become one. Tim Tebow, who is now a broadcaster, still has this incredible, youthful, spiky crew look. And those guys in particular, this is the question that's kind of leading into this. Do you think hairlines matter now a lot more with HD cameras and social media, specifically for broadcasters? Because they don't have these nice cinematic cameras like, this FX30 I have here that makes you look, tones everything down, makes you look great. But in HD, everything is noticeable. And when you have a hairline that's great in HD, it looks incredible. Tim Tebow, I just always go back to him as a broadcaster and football player, and he just looks great.
For sure. I think the HD cameras are less forgiving to, small imperfections. And obviously people who are attuned to hair in general are going to be able to pick up on all the little imperfections more easily because it's more difficult to hide. But people want to look good and feel good. When you look good, you wake up in the morning and you look in the mirror and you're going to have a good hair day. You feel good. There's a part of you that think this is going to be a good day. And that might permeate into the way you walk, might permeate into how you carry yourself, perhaps your posture, you might stand a little taller, chest a little further out. These things do affect how you feel. You feel like living a little bit harder, maybe a little bit, more than, on the days where you wake up, you look in the mirror and you don't like what you see. So I think that, yes, hair is a huge contributor to people's confidence. And I think that people who are broadcasting, who are in that public spotlight definitely feel more confident speaking to millions of people because they have a good hairline, for example, you know?
Yeah, I agree. It's really interesting to see how some guys in the sports broadcasting regions, they still look great. Some guys, and to paraphrase this quote, like you said, Deion Sanders said, when you look good, you feel good. And when you feel good, you perform good. That's a big paraphrase, but I believe he used to say that all the time. And he's right. And Deion Sanders has had a hair transplant, still looks good, aging very well. And it's a testament to hair really changes the man. Like you said, makes you walk different, talk different, everything. Things just kind of get a little bit better for your life when you have a great head of hair. London versus America. Here's some hair grooming questions I have for you. Do you see a difference in how men style their hair in the UK or specifically London? London's very stylish versus like America here in the US. I know you don't have a lot of experience coming over here, but do you see varying differences that you might see on television or in social media for the way guys specifically want their hair styled versus the United States?
For sure. I think that British guys tend to wear their hair a little shorter in general from what I've seen. So the classic short back and sides with a heavy on top is quite a common appearance that I see with a lot of the British patients that come in. American patients, now I'm over simplifying this, and not every patient like this, but American patients tend to wear their hair a little longer from what I've seen. I think that when they have good hair, they tend to enjoy it. You know, they grow it out longer and you know, they leave the sides longer and it flows a little more, if you like. Whereas there's a lot of guys who have a brilliant head of hair over here. I wish they grew it out. I wish they showed it off. I wish they showed just how beautiful their hair really is sometimes, because when you cut it and you hack it and you create a fade, you can almost look like the next guy. But sometimes these British guys actually have incredible heads of hair and you would never know. How does that affect things? I found that it can be more difficult to recommend strip FUT surgery over here because people are much more concerned with keeping the back and sides short. And of course, that linear scar that does come from strip FUT. So there is a big difference. I think that Americans are almost a little bit more like Italians. You know, they wear their hair a little bit longer when they have it and they enjoy it a little more, especially over in California where you are, where the sun shines. It's that those long flowy locks in the sunshine with the roof down, going fast along the beach. It's all that, that unfortunately under the UK gray skies, we don't perhaps have that culture.
As an Italian myself, I you know, my hair started to go when I was like 18, 19, and I used to have long flowing brown, dark hair, but that subsequently changed when I started to lose my hair. So if I could get it back, I would. And you're right. I know exactly what you're talking about. If I had the long flowing locks, oh man, I would flow it out. I think it's an easier way to simplify styling your hair when you have just nice flowing locks. And I'll try to post photos of what we're talking about here to show examples. When you don't have to spike or style your hair, when you can just wake up and put some product and flow it back and just go, man, I wish I could get back to that when I was younger because it makes it so much easier. It's just an easier way of going about life and not have to worry about getting the perfect style for fading and spiking up or keeping it curly on the top. So
sure.
With that, do you think patients in the UK are wanting more conservative or are you seeing more aggressive hairlines that these guys are wanting based off of other areas for hair transplantation, be it America, Australia, Turkey, Spain? These guys come in and do you think they want more aggressive hairlines?
I would say not. Having observed quite a big patient database when I was over in the US with Dr. Bloxham, comparing them to my patients over here, I think there's a difference. I think that UK patients have a natural kind of conservative approach. I think that they're much more concerned with it being discreet. There's a little bit of a stigma still hang around here in terms of vanity, unfortunately. So California especially, vanity is, you know, everyone's got it, everyone's expressing it, and it's not a big deal, you know, where everyone's trying to look good and feel good. But over in the UK, at times, I think people are more concerned with being discreet. Now, I'm not complaining about that. I get it. I wanted my post-transplant process to be discreet. But I think that how that affects hairline design is that patients can be more conservative and go for slightly higher hairlines, smaller areas worked in, FUE mostly. And that's just a difference. You know, it's not better or worse. It's just a difference I've seen. I love it actually because I always go with the patient when they want a conservative hairline. The worst is if we bring the hairline much too low and put the patient in a bad situation in the future. We sacrifice on density because we're working in a larger area. If we raise the hairline and make the hairline a little bit more conservative, we save on grafts, we aim for more density, and it looks, you know, potentially more natural.
I agree. And I think there's a couple guys in Hollywood that come to mind. Jude Law, who I believe has had a little one, he still has that signature receding hairline that he's sort of always had, but he looks good. just bringing back a little bit of hair makes them look good. I talked about this with Mr. Rolandis also. Joel McHale, great conservative sort of pseudo receding hairline that's now thickened up, not going to go anywhere, looks great. Timothy Oliphant, another guy, looks great. I know Matt Damon, I don't know personally, but you can tell he still has a very subtle recede, but he had a minor, I think, fixed up there on the temples as well as hairline. He also looks great, but it's very conservative. And just a little bit goes a long way. And I think a lot of guys forget that. Rather than going aggressive, adding a couple centimeters to your hairline or to your temples, it really changes your look. It really outlines your face. And we don't have to go as aggressive as we think. Conserving the hairline, conserving the donor region, it's a great way to just add subtle changes, like you said, to really enhance someone's look. A little bit really does go a long way.
I agree.
You know, let's say a guy's got a receding hairline and maybe a little bit of crown balding. How does that affect the way you discuss a surgical process with them? So let's say a guy comes to you with a Norwood 3 and a little bit of crown. How do you discuss FUT or FUE with them versus just the benefits of both or the statistics of both, whatever they are? How does that affect the way you approach a patient? How do you talk to them when they're first coming in? Do you let them kind of guide what they've learned first and then educate them on the types of surgeries and the outcomes?
Absolutely. Yeah. So the first thing I love to do is assess what I'm working with. So I want to know how much the patient knows. And I'll ask the patient, tell me about what you know so far. Tell me about the research that you've done so far. What are you thinking? And I'm able to gauge, first of all, have they done any research? Are they coming in completely blind and do we need to start from the beginning? Or, have they already made up their mind about where they want to take this? In which case, I'll work with that. I don't go hard and fast and stop patients from doing what they want to do, but within reason, because my signature is on that result as well. So it really is a negotiation. It's working together to come to a final agreement. We are, and I like to remind my patients, I'm on your side. This is a teamwork decision, and it's not me versus you or my decision versus yours. And so that really allows us both to aim towards the common goal, which is for the patient to be happy with their result. And of course, FUE versus FUT very much comes into that. And what I'm seeing is that there's some patients who are just FUE candidates, and there's some that are FUT candidates. And there's sort of two parts to that. The first is how advanced the hair loss is, and from a surgical point of view, whether they're an FUE, FUT candidate. But the second is from a psychological point of view. And I'm seeing, some patients just aren't candidates for strip FUT. And I understand that because they wear their hair very, very short, or because the linear scar just bothers them to tomorrow and forever. They just feel so irritated and bothered by it. So I understand, and I'm not going to force someone in the corner. It is a cosmetic procedure. If they value a lack of a linear scar for fewer lifetime grafts, that's fine. But they need to be aware of that. And that's where, education and informing the patient comes in. So it is a negotiation. That's the key point here. I'm flexible, but also passionate, and I have principles as well. So that's my overall approach to, Norwood 3 patient who comes in to my clinic.
Do you think with modern strip techniques, and what I mean by modern is, I guess, getting better surgically using newer tools. We always have new tools coming out. Do you think FUT actually offers more flexibility? Because a lot of guys don't know this. There's a multitude of ways to suture or close up that scar. We've got sutures themselves, which can theoretically close off oxygenation, right? We've got staples, which in theory provide more oxygenation or better blood flow to that actual scar region. I've had both. I've had both the sutures from Dr. Meshkin, and then I've had the staples with Dr. Bloxam. And the healing time is about the same. The feeling is different. Staples hurt when you're removing them, but they both have their benefits, I think. There's a trichophytic closure, and a lot of guys don't know this. So tell me, which type of closure are you currently using? And are you sticking with one and refining that? And are there any biologics, such as stem cells, that we can now utilize for healing scars? We're seeing that a lot, amniotic stem cells within the scar post-operatively. So yeah, tell me which type of closure technique you prefer, what you're using, and then do you think biologics in the future could help with the healing process to really, truly refine a strip surgery?
Yeah, that's a good question. So with closure of the strip, I am currently utilizing deep sutures and then superficial sutures. So I find that to be the most consistent closure technique. I find that it gets the best scars. I would say that 90% of the time you're getting a 2 millimeter scar. And that's as if you were to take a Sharpie pen and just draw a white line to the, little smiley face on the back of the head. So that's what I am getting from using deep sutures and then superficial sutures. We use absorbable deep sutures, so they absorb. You don't need to cut those out. And I experiment. Sometimes I use absorbable superficial sutures, but most of the time we use nylon superficial sutures, which we have to remove after 10 days. And the scars are great. They really are great. But there are little tweaks, little changes in terms of patient to patient. So if it's a virgin patient it's his first strip, then I don't need to use as many deep sutures to close because there's plenty of laxity. If it's a patient who's had, 4 strip procedures, if it was someone like yourself, for example, you might have a little less laxity now, and we might need to use more deep sutures to really bring it closed. So that's generally my approach to FUT closure. I do use staples every once in a while. Contrary to popular belief, they also heal brilliantly. I had staples myself. You do end up looking a little bit like Frankenstein at the back there, but once those staples are removed, it leaves behind a scar that looks really good. So I don't have issue with staples at all. With respect to biologics, I'm going to have to ask you what you've seen, what kind of research you've seen with biologics.
I used to work in sales for a company, CTM Biomedical, and we were selling amniotic stem cells, specifically started in ear, nose, and throat surgery, closures for ear, nose, and throat, utilizing these either deep packing, subcutaneous injections, or basically closure, and then take a sub-Q and go right underneath of there. And it was an amniotic stem cell. Specifically, you would see it a lot in post-op. So closing up a knee, closing up an ankle surgery. Once you're closed, you go ahead and you inject, and helps with, theoretically, right? There's still a lot of research coming on this, but for healing with scars. And Dr. Bloxham and his other clinic down in Florida were utilizing this to help with the closure of FUT. There's still a lot more studies, but there were some promising results to help reduce that scar, to help bring back some pigmentation, right? Because that's the biggest thing, is we lose that skin pigmentation, and sometimes you'll get the railroad effects with the staples. I never got those. I didn't have any of the railroad clamping that you see with staples. Some guys get that because the pigmentation changes. So it was essentially trying to help reduce that scarring, return some laxity to the skin so it's not as tight, and there's still a lot more to go through. They utilize this stuff a lot in ear, nose, and throat, or any type of surgeries that are around the chin, periorbital region, because you need a lot of laxity here for movement, right? Vestibular system, everything here. So it was developed by a team for ear, nose, and throat surgeons. And I was working for this company. I was like, well, we could probably sell this to hair transplant surgeons. And that's when I reached out to Dr. Bloxham. He's seen some good results now. I don't know how much we're using it in hair transplant surgeons. I think it would be great to get more of it out there. But this is just one thing that we can use within our toolbox to help with scarring and stuff. What size punch are you using typically, do you see, for your FUE procedures?
Yeah. So punch size is a tricky one. So the punch size varies from company to company. So if you buy a punch from one company that is, say, 1 millimeter wide versus another company that says 1 millimeter wide, they are not necessarily the same size, unfortunately. There's reasons for that. So some companies use the internal diameter of the punch to describe the size of the punch, and other ones use the external diameter. So you need to be careful and wary when some surgeons say, oh, I use a 0.6 millimeter punch. Are they referring to the external diameter or the internal diameter? It can give a sense of false information. So myself, I use a 0.9 millimeter punch usually. I might at times go up to a 1 millimeter punch depending on the size of the patient's grafts. I find that to give very good scars. We use the DeVroy Wall FUE machine, which is currently one of the state-of-the-art machines, one of the most expensive and, more importantly, effective machines that is out there currently. And we use the hybrid punch, which comes with that machine. So it utilizes a technology that, even though the punch size is a little bit larger at 0.9 or 1 millimeter, the size of the holes that it leaves behind is so small. You would struggle to find the FUE scars in most of my patients, and yet I'm getting the graft out beautifully. I know it's a very commonly used machine and size of punch. I know Dr. Ted Milne, who's one of my colleagues over here delivering great work, also uses the same approach. So yeah, it works, very well for me. At times I'll go lower, if the patient has already been quite strongly harvested, if they've had a lot of grafts taken before, and I want to minimize scarring, I'll go down to 0.8 millimeters, something like that. But in general, I find the 0.9 to 1 millimeter range to be very, very effective.
And with regards to FUE in particular, describe to some people who might not know this, what transection of a graft actually mean and where it specifically occurs. Because a lot of guys don't realize, will say, well, FUE's survival rate can be different because it's a blind punch. So if you could kind of describe what we mean by a blind punch and why there tends to be a higher transection rate sometimes with FUE. Not always. I'm not saying one's better than the other because we know the strip, you can go in and get it directly, stripping and seeing all of those grafts. But give our listeners who don't understand what transection is in a graft and why that can be bad for growth.
Yeah, for sure. So this is a good example here. I'm going to use these two pens. So we can see imagine this is the surface of the skin, and this is the hair follicle poking out of the surface of the skin. Okay. Now we can see this top part of the hair follicle here. We can see that from above, but we cannot see this bottom part here. Okay. So this bottom part is not visible. Now some hair follicles are nice and straight like this, but other hair follicles can be like this. They can be flat against the skin, and they can also have a curl or a coil in the area underneath the skin as well. And that means that when we go in and we take a punch to score around the graft and go all the way down to the bottom of the follicle, we're going in blind because we can damage this part here. Once I'm here with the punch, I don't know whether I am damaging the follicle like this, cutting the follicle like this, or whether I'm cleanly taking the follicle with one nice smooth punch. Now, it takes skill, experience to be able to do a nice clean punch every time. And FUE is generally really good. It does most of the time take beautiful grafts, but there is a chance that if improperly performed, we can transect the graft, and that just means cutting it in half, and of course, killing it, damaging it, and obviously it won't grow.
And as we know, we're not just taking one singular graft, and I think a lot of guys don't understand this. There could be the possibility of transecting a 3 graft, right? So you have 3 hairs coming out of the graft, and maybe only 2 survive. So we lose a little bit of that thickness that you otherwise would have if you got the entire graft out of the body and then reimplanted into your whatever frontal region or crown. Which brings me to kind of one other topic about survival you mentioned, and a lot of guys don't understand this. FUT is a little bit faster of a procedure because you're taking that strip out, you're cutting it down, you're getting those slits done, versus FUE. It's a long procedure, and what most guys don't realize is the hair follicle is an organ. And it does not like to survive outside of the body, just like a fish outside of water. We need to move that follicle from the back of the head, take it out, clean it up, and then get it back in as quickly as possible for a survival rate. So a lot of guys tend to forget that could also contribute to the lack of survival. So is that something you try to educate a lot of your patients with regards to survival? It's a hair follicle, but it's also an organ, and it wants to be back in the body as quickly as possible.
Absolutely. Just like if you were to transplant a heart, you keep it outside the body for too long, it's going to die. It's an organ. A hair follicle is a mini organ. So we need to prioritize minimizing time outside the body. And yes, as you said, strip FUT, when performed with a large team of technicians, can be incredibly fast and incredibly efficient. And we can get those grafts out, and they remain in the tissue, by the way, when they are out of the body, because there's obviously tissue that we brought with the strip, which, if I was to hypothesize, I do believe will contribute to slightly better growth. But that said, I'm a proponent of both FUE and FUT, and we do work very fast, at least in my clinic, with FUE as well, to make sure that those grafts get back into the recipient area as fast as possible. So I think absolutely, but also with the right team and the right speed, both procedures can be performed very well.
Another technique that Dr. Bloxam and I have been talking about a lot and trying to come up with a name with this is the pre-slits. The night before a surgery, be it FUT or FUE. Have you worked with Dr. Bloxam at all doing pre-slits or any on your own? I know some other surgeons in Chicago are doing this. And if you can touch on that a little bit and explain to the listeners what a pre-slit technique would be coming in the night before, and how theoretically the cytokines, all the stuff in the blood, the healing factors of blood that are coming to the subcutaneous and the blood that your brain sends, these signals to heal, are already there and prepped for possibly implanting those grafts to increase survival rate. So could you touch on that a little bit, if you've had any experience with that with Dr. Bloxam or on your own?
So I personally haven't done pre-slits, but what pre-slits are, for those patients that don't know yet, the graft needs to be inserted into the skin. And for it to be inserted into the skin, there needs to be a slit, a hole essentially for the graft to slip into. And those holes are called incisions or slits, and we make those before we implant the grafts. And we do thousands of those to implant thousands of grafts. And you can either do the incisions, those slits, on the day of the procedure, or you can do them the night before. Now, from what I've seen the night before, I have worked with doctors who perform it. It's not clear. There's no real concrete research to show whether it's better. I can see the appeal in that you might be able to harvest more grafts the day of the surgery because you don't need to waste time making the incisions. However, there is a possible theory that leaving 12 hours between making the incisions and implanting the grafts, and often it's longer actually. You might implant the graft 16 hours after making the incisions. The issue that some people have said is that the incisions themselves might start scarring and healing. And that could, number one, contribute to making it more difficult to push the graft into the incisions. But also, number two, if that incision site has already started healing with scar tissue, it's not going to soak up and provide the blood supply to the graft that the graft needs. So that's one theory. It's one of the reasons why I don't do it. I don't want to be taking any risks with growth or the results for my patients. But yeah, I can see how it might make the day go a little smoother. But yeah, certainly I won't be doing it anytime soon.
Yeah, it's just an interesting topic that Dr. Blocks and I have talked about. I haven't researched it much myself. I don't really know the surgical ramifications of that. Like you said, does it heal? And everybody's body heals faster, right? So you could do pre-slits on someone and in 6 hours, they're closed up. And then you have to go through and then make those slits again. So just an interesting topic that's kind of been brought up. I've seen a little bit online and some other surgeons doing it. So I guess we'll see in the future what happens. So another topic I wanted to hit on was UK football players, because you live in the UK. I love football, soccer here in America. I played soccer my whole life. So who do you think's had some really great outcomes? I'll give some names here, and I kind of added them to the list from last night. We've got David Beckham, who has maintained, another guy who's had this great hairstyle, but we all know that he's lost his hair a little bit. You and I have discussed online a little bit about his surgical technique or the temples and how it's kind of a little bit more, I don't want to say feminine, we'll say rounded, right? But that's typically what a female's hairline looks like, rounded. He still has great hair. I believe that he utilizes a combination of topic in there or whatever to thicken up his hair, because sometimes it looks really, really good, spiky. He maintains that crew cut look. And then other guys, Mo Salah, Andros Townsend, Caleb Chambers, Rob Holding. I don't know if you know any of these. I hope you're watching soccer. Some of these guys are in Arsenal. But tell me a little bit what you think of David Beckham, since he's like the most popular of all of these soccer football players.
Sure. So David Beckham, I'm 100% sure it's had a hair transplant. If you look at the photos from when he was younger, he was showing signs of diffuse thinning. So he's mostly a diffuse thinning patient. And what I believe he's had is likely a frontal third procedure. So I think he's had FUE hair transplant surgery, and they've taken, say, 3,000 grafts and really solidified the front. Now, it's possible he might have had work even further behind that, given that he was a diffuse thinner. But as you said, the issue that some people have highlighted is that the hairline design isn't 100% natural looking. And it's mainly shown in that little region that connects between the hairline into the temple points on the right and left side. So on the sides of the hairline there. And that curve is very classic of hair transplants. That's the kind of telltale sign that someone's had a hair transplant. And I think, it works for him, especially when he wears his hair long. I think when he wears his hair shorter in a buzz cut, it looks a little bit more obvious. And that was shown in his Wimbledon photos. When he was at the most recent Wimbledon championship, he had his hair short. And you could really see, how unnatural it looked in that little area there. But otherwise, he's definitely gotten lucky. As you said, I think he uses product, likely a thickening, volumizing powder to boost the texture and volume of the hair. Because, as I said, he lacks density more so than, a clear recession or crown thinning, for example. So I think he's experiencing thinning all over. So that's my impression of David Beckham. I'd say, he got good growth. He's done it well. He did it discreetly, but I don't think he's quite gotten away with it. I think, it certainly could be improved.
Another one that comes to mind from his time period was Wayne Rooney, who famously had one, but looking at his photos, I'm not sure if he was really keeping up with his medication, right? Because you could see that it really diffused back behind the hairline prior to what we see now. I think he might have had some more work done. I haven't really checked up. But just looking at his older photos to now, you can see there was this transition where he got a little bit of the hairline and then lost a little bit more and then got a little bit back. So I think it's a classic case of someone not keeping up with medication, which is something that a lot of guys don't understand, is you have to be on medication to maintain what you have behind your new growth. And I have some friends who have had hair transplant surgery, and they'll say this, they'll say, well, I got the surgery, so I don't need to take medication. And I roll my eyes and I try to calmly educate them and say, look, if you do not take medication to mitigate the effects of DHT, everything behind that newly formed hairline could theoretically, not everyone, because not everyone's going to go that far, but you will most likely continue to thin out, and then you'll be stuck with, oh, I thought that I wouldn't lose any more hair. So education is a really big thing for people pre-op, post-op, maintaining the hair. It's just something that should be, I think it should be just universally known that you have to be on a medication, finasteride, dutasteride, to prevent the harmful effects of continually losing your hair. And like I said, I have friends who tell me, oh, I went to Turkey, got my hair transplant. And I'm like, that's great. You look great. What are you doing to maintain the rest? Well, I got the transplant because I don't want to take medication. And there's just that barrier to understanding how hair loss is stopped and how hair loss is kept. And a lot of guys just don't, I just say they're not educated enough to understand that. They jump into these things really quickly without thinking long term.
I agree.
So what separates to you in your experience, you said a year, you've been doing this a year, but you've seen a lot. What separates a good transplant from a bad one as a surgeon?
I think as a surgeon, it's attention to detail. And I mean, there's quite a few things here, I think. First of all, it's attention to detail. Second of all, it's artistry. So, some surgeons have it, some surgeons don't. Unfortunately, it's not something you can kind of, buy at the supermarket. It is something perhaps that you can learn and get better at. And that's why you see those really beautiful hairlines from some surgeons and then other ones, not so much. I'd also say, a willingness to go dense as well. And that's not something that every single surgeon does. I think, especially in the hairline, it's important to go dense. People want density. Expectations are increasing. People want to look good, want to feel good, as we mentioned earlier, and density is key to that. So I think density, artistry, and attention to detail, I always say that how you treat one graft is how you treat all of the grafts. So it really is important to observe your technicians implanting those grafts, to keep track of every single graft, maintain accurate counts throughout the day, correctly place the specific type of graft, the singles in the hairline and the multis further behind, and just having one patient per day. All of these things contribute to a great result. And you need passion. You need to be obsessed with this sort of thing to give patients good results.
Yeah, and I think you brought up a really good point discussing how you understand the details of David Beckham's hairline, right? We as patients or people who aren't involved in surgery and have never had a hair transplant will see David Beckham and be like, oh yeah, he's got this hairline that's like this. And oh yeah, he had a hair transplant, but they don't understand the intricacies of pulling in temporal points, lowering the hairline appropriately, keeping it to look mature. Some guys will see guys and be like, oh yeah, he has a hair transplant because he just, it's just straight across. And that's what a lot of individuals who aren't in the space assume a hair transplant looks like, instead of a surgeon like yourself who pays attention to detail to making it look natural and making it look as though you've never had a hair transplant, right? That you're just returning back to somewhat of a normal hairline, not an artificial hairline, which a lot of guys today tend to think is a hair transplant. This artificial hairline going straight across the head, which we see a lot, unfortunately, in influencer culture and some other clients that we've seen around the world, right? People go from the United States to another country and get a hairline and that's it. And there is no attention to detail. It's all the same. It's just the same hairline that people are getting, right? And that's what a lot of individuals who are in the medical field assume a hair transplant is supposed to look like. And that is far, far from the truth. So patient preparation and education. So how do you personally prepare a patient pre-op? So let's say a guy signs up with you and he's 6 months out. Is there anything that you send him, educate him with prior to the surgery that he should know? And then when they're there the day of the surgery, how are you prepping the hairline?
Yeah, absolutely. So before the procedure, it's almost mandatory to get a consultation, and I prefer in-person consultation. So get the patient to come into the clinic. I'll be able to see the patient in situ. And sometimes photos are not enough because, I can't see how large the patient's head is, for example, which actually makes a big difference. I want to understand his expectations, his demeanor or her demeanor, and seeing them in person is pretty key to that. Obviously, during the consultation, we assess the hair. I take a history examination. And in the examination, I use trichoscopy, which is a high-powered digital microscope to assess the hair follicles in detail. It allows me to predict further loss, assess the quality of the donor area, see whether the hair loss is likely to recede further behind, for example. Very, very helpful. And then, of course, offer the opportunity for the patient to ask any questions, because there are a lot of questions. There's a lot that needs to be learned. Patients have an abundance of questions. So that's a very good chance to iron everything out. And then once the patient books with us, for example, we give a surgical packet, which essentially is quite a long, extensive document detailing how the procedure is going to go, detailing importance of avoiding things like alcohol, ibuprofen, and other non-steroidal medications, and a few other tips and tricks to make sure that the day on the surgery day goes smoothly. And then on the day itself, patients don't usually have issues. It's a smooth day. We do most of the work. That's why I tell the patient, they only have to sit back, relax, and watch Netflix or Amazon Prime, something like that. They have the opportunity to get up, stretch, go to the bathroom. We get a little bit of anti-anxiety medication to make sure everyone's nice and relaxed. And the patient's awake. It's quite a unique operation in that it's very, very long, but the patients are also awake. And in most procedures in the hospital that are very long, the patient is asleep. This is an interesting experience, and it's interesting to speak with patients all day. I love getting to know my patients. Them being awake gives me the opportunity to learn a little bit about them. It makes the day go a little faster, able to ask about their job, and I really enjoy it.
Now, are you utilizing any drip therapy, any Versed, anything drip injectables to calm them down, or is everything superficial injectables in the head for numbing?
So for numbing, we just use a lidocaine with a little bit of adrenaline or epinephrine, and that really, does the trick. We use a small 30 gauge needle, which essentially feels like a little bit of a bee sting, and it's very small. Patients usually don't have much issue with it. The hardest part is the initial pokes that we do. The numbing process is pretty well tolerated. That's sort of the main thing. We use a little bit of saline as well. So I like to pump up the tissue. It allows for more density because we're pumping it up, we're putting more grafts in there. And then when the swelling goes down, the grafts come close together and density is a little higher. So those are the main kind of injectables that we use over here.
What's the biggest lesson you've learned so far from Dr. Bloxham?
So I've learned a lot of lessons from Dr. Bloxham. One of the biggest lessons I would say would be the importance of using very small, fine tools to make incisions. One thing that, I'm very proud that we offer is customized blade sizes. So unfortunately, there is, again, in other clinics, there is a kind of a one-size-fits-all model. And what I mean by that is that the incisions that are made to insert the grafts are one size and one size only. And it's not customized to the patient's graft sizes, because some patients have big grafts, chunky grafts, other patients have narrow grafts. And with those patients have narrow grafts, the wider incision blades are unnecessary. We can go smaller, we can go more dense, and that allows for more of a better cosmetic result. So I think Dr. Bloxham's insistence on using the smallest tools possible to achieve the highest density is one of the unique things that he does, and one of the most important things that I've brought over to the UK.
It's pretty good. So what are things patients really misunderstand about post-op? Because that tends to be a big thing that I have friends who get hair transplant, and I'm like, cover up your head, 6 months, keep it covered. So what are some things that's really hard to emphasize, or something that patients don't understand, coming out of surgery, how long? It's a long process, right? You're not going to get those full results until 12, 15 months sometimes, and then the ugly duckling phase, which a lot of guys aren't educated on. I tell my friends, just be prepared to have a year of looking kind of funky, but know that everything is going to turn out great. Be positive, protect your scalp, protect your hairline. So what do you try to educate patients on post-operatively, what they can expect?
So most of my patients have been very good in the immediate post-operative period. They look after their grafts very well. They want to get the maximum results. I don't usually get any problems in the immediate post-op period. But as you said, the hardest part of the hair transplant process is just the waiting game. Yeah. It's just so damn long to wait, and I get that as a patient, especially. I remember feeling so frustrated, month 5, month 6, you just want it all to come. It's boring, it's frustrating. And as you said, in the end, we go one step back for 2 steps forward. That's how I motivate my patients. So that's sort of the hardest thing to push through. It's the emails at times of patients who are very worried about their results. They're month 3, month 4, and they're saying, "No, doc, why am I not seeing a full head of hair yet?" And I see myself as somewhat of a, bit of a coach, where I need to instill patience, instill motivation into these patients to still have faith that, everything will turn out okay. So I'd say that's the biggest challenge at times with some patients.
Why is long-term planning way more important than surgery itself?
So long-term planning is important because we're dealing with a finite supply of grafts in the donor area. And as Dr. Bloxham has said before, we want to treat hair loss like a game of chess. You want to get one move ahead of the hair loss. So long-term planning is the way to do that. We don't want to just obliterate the donor area. Say a Norwood 4, Norwood 5 patient who's 25 years old, comes to me wanting a full head of hair. I'm not going to go in there and obliterate his donor area with FUEs, take 7,000 grafts, empty his donor area in a way so that he has none to use in the future. Instead, I might encourage him to hop on medication, see how much regrowth we can get. Maybe focus on the front instead of the crown to begin with. Maybe use oral minoxidil to boost the crown and use surgery to boost the front. Maybe utilize strip FUT to maximize the efficiency of the donor area so that he has access to more in the future. There's a way to go about this responsibly, and ensuring the long-term journey is thought about is key.
If you could tell men one thing before they ever consider a hair transplant, what would it be?
Are you ready to embark on this journey? Because it is a journey. It's not as simple as a quick fix. It's a strategy. It's a long-term journey. It's planning. It's not panic. It's not getting the problem solved overnight. It's not unlimited grafts. It's not overnight growth. It's a waiting game. It's patience, and it's being smart about it. And the question I'd ask is, are you ready to begin that?
That's pretty good. So hair transplant surgery is a game of chess. We could sum it up to that, right? So let me ask you a couple more personal questions now. We'll end on some fun stuff here. So what do you like to do in your spare time when you're not doing surgery?
What I like to do in my spare time, I go to the gym a lot. I think caring about your hair and caring about your physique go hand in hand. Again, it's about looking good, feeling good, but also the psychological benefits of going to the gym are key for me. I am running a business, and I sometimes find it very difficult to switch off. So going to the gym is an incredible release. After that gym session, I just feel, $1 million compared to before at times. So I'd say the gym. And then I also love to read. I read a lot. I read literature. I read, scientific literature, and I read English literature. I love art, and I love music, and I love film. I saw the recent film from Timothée Chalamet's Marty Supreme, which was really good, actually. I really enjoyed it. I go to the theater a lot, the movie theater, and exercise plenty.
What's your current weekly split for workout? Are you like Monday, Wednesday, Friday, push, pull, leg, shoulders, or what do you do? What's your split?
So current split is focusing on my weak points. So now we're getting personal, because I'm about to tell you my weak points. My weak points this gets my heart racing a lot more than any other question. So the weak points would be my calves. This is a typical weakness for a lot of men.
With you.
I think a lot of guys are, because a lot of people can relate to this. They just don't grow. It's frustrating. So I've upped the calf training to 3 times per week. I tend to have stronger body parts that I don't focus on. So for me, I like to focus on my weak points, just like I like to do in surgery as well. I like to focus on the parts of me that I'm not doing quite well enough. And, I apply that same logic to the gym.
Well, you already answered this question. What's a movie you've watched recently in the last year? Because we're in 2026, so I guess you watched Marty Supreme within the last year. So that's good. What's the last book you read, actually?
The last book that I read was Ernest Hemingway, one called Farewell to Arms. It's really good. It's about him during the war period, where he falls in love with a nurse, and it's so romantic. It's a heart killer, but I love it. Again, it's escaping from the medicine world. That's the most recent book I read. I'll
read The Great Gatsby like once every year, and I'll listen to it. Jake Gyllenhaal did a good reading of it. So I'll try to go through that like once a year just to remind. I love that book. I've read a lot of Hemingway as well. I just finished Annie Jacobson's Area 51. Really cool book about the history of Area 51. So yeah, she's got some great books. I love to read a lot. That's good to hear that you kind of go back to the classics a little bit. A lot of guys don't do that, but I'll try to find a classic book once, every 6 months to cycle through on Audible or something I'm reading. So that's good to hear. What's something people would be surprised to learn about you? Other than you have small calves, what's your favorite food? Because you're in the UK, so we'll say that. Favorite food has probably got to be lasagna. I think the homely, motherly, nurturing nature of lasagna, I feel like. The way it just reminds you of feeling looked after. I love that meal. I'm a sucker for lasagna. I love spaghetti bolognese because of it as well. So that's how I judge Italian restaurants. Is every time I go to a new Italian restaurant, the first thing I order is bolognese to test how good that is. And if that sauce is not good, I'm not coming back. 100%. Have you been to Italy? Have you been to Italy and ate over there? One of my best friends is from Rome. I've been to a particular restaurant called Osteria da Fortunata, which I would recommend to anyone who's going to Rome. It's incredible. The pasta's incredible. Certainly passes you or spaghetti bolognese check. And I'd get the amatriciana if you go there. It's really incredible. If you weren't in medicine, what do you think you'd be doing? I'd probably be a headless chicken. I don't know. I think perhaps some people have said, I'm a bit of a
chatterbox, I'd maybe be a lawyer or something like that. But it would have to be something high stakes, something thrilling, exhilarating, something that feels like something's on the line. I do enjoy that.
I can see that. If you're reading classic literature and you like to speak, that kind of fits the history into politics, right? So that's a lot of guys go through history, politics, and then become a lawyer. So it could be a great fit for you. So we'll end on this. What's something you are genuinely excited about right now, professionally or personally, going into the new year?
As cheesy as it sounds, it's seeing the post-op results. I think of the surgeries that I've done last year, I am absolutely on the edge of my seat to see how they've come out. I've seen a few that I did obviously at the start of 2025, but the ones that I've done recently, the reactions to the results as well, the photos that we're going to take, the posts that I'm going to make about them, all of that is just so exciting. It keeps me going, to be honest. So that would be the main thing professionally. And then personally, it's just more family time, more friendships, and more classic literature and calf training.
All good things going into the new year. Dr. Parissis, this was awesome. Thanks for finally joining me on here, aside from chatting and Instagram and stuff. And I'm sure, hopefully, I can get over to London with Dr. Bloxham to hang out sometime. And you can get back here to California. We'll take a break from New York and come over to the West Coast, a little bit more sunshine and stuff. You can show off your calves, because I know you're probably wearing pants all the time in the UK. So thanks for joining me today. I'll try to post all the photos we can along with this video, and I'll post all the links for you, your surgery clinic, and your socials below. So thanks, guys. I hope this was informative for everyone. Dr. Parissis, thanks so much. And we'll do this again, right?
Perfect. Amazing. Thanks.
This podcast was produced by Pod Punch Studios. Stay tuned for more episodes of the Mane and Steel podcast. Be sure to like, subscribe, and leave a review wherever you're listening. Until then, keep moving forward.